Anyway, Dr. Akshay Mohan, na?
Yes, sir.
Okay, you start with your presentation.
I'm going to present
Please
about.
note the time, 4 minutes.
I'm going to present about orthoptic importance of refractive correction in phakic plane in unilateral high refractive errors, a case series. As we all know, anisometropia causes disparity in focus and difference in clarity of size of image on retina, which results in the impairment of fusion, often leading to strabismus. This deviation remains largely unchanged with use of glasses, but with refractive correction by other means like phakic IOLs, clear lens exchange with multifocal IOLs, piggyback IOLs, etc., this significantly improves the quality of vision, enhances binocular function, and has a positive impact on ocular deviations. Aim is to study the effect of refractive correction in phakic plane on orthoptic parameters and stereopsis in unilateral anisometropic high refractive errors. We report a case series of 4 patients proving the orthoptic relevance of surgical refractive correction in unilateral high refractive errors in young adults. The patients underwent surgery after informed consent. First case was a 21-year-old male having 6/6 vision in the right eye, and in left eye his vision improved to 636 with +8 diopter sphere. Patient had left exotropia of 35 prism diopters and left eye suppression. Diagnosis was severe aniso-hypermetropic amblyopia in left eye with sensory left exotropia. Patient underwent clear lens extraction with multifocal IOL. The AC depth was 2.4 mm, and patient wanted to be spectacle free, so this was the only choice. In post-op period, the patient's vision improved to 612 and control of exotropia also improved. The stereopsis on Rendot improved to 160 seconds of arc. This is the pre-operative and post-operative photograph of the patient. Post-operative photograph showing control of exotropia post-surgery. Second case was 20-year-old male medical student facing difficulty in enjoying binocular vision while looking through a microscope. Patient has undergone a repair of corneal penetrating injury with lens aspiration and in the back IOL implantation in left eye 8 years back. Patient's visual acuity in right eye was 6/6 and in left eye it improved to 612 with -8 diopter sphere. Patient had glaucoma adherence with pseudophakia in the left eye and also left eye suppression. So diagnosis was glaucoma adherence with pseudophakia with anisomyopia in left eye. Patient underwent piggyback IOL implantation in the left eye. The vision improved to 612 and stereopsis on Rendot was documented to 100 seconds of arc post-operatively. This is the pre-operative and post-operative slit-lamp photograph of the patient. A is the pre-operative photograph and B and C is the post-operative photograph after piggyback IOL implantation. Third case was a 21-year-old female having -4.5 diopter sphere in right eye and in left eye -20 diopter sphere through which vision improved to 660 and there was left exotropia of 30 prism diopters and left eye suppression. Diagnosis was myopia both eyes with sensory left exotropia. Patient underwent implantable colamer lens implantation both eyes. The power was in right eye was -6.5 and left eye was -23 diopter sphere. In post-operative, the vision in right eye improved to 6/6 and left eye improved to 624 with -0.75 diopter sphere. The patient was orthophoric for both near and distance and stereopsis on Rendot improved to 160 seconds of arc. This is the pre-operative and post-operative photograph of the patient showing control of exotropia. Case 4 was a 23-year-old female having 6/6 vision in the right eye and -15 diopter sphere in the left eye through which vision improved to 624 and there was 35 prism diopters of left exotropia and left eye suppression. Diagnosis was high myopia with amblyopia in left eye with sensory left exotropia. Patient underwent implantable colamer lens implantation in the left eye. Power was -17.5 diopter sphere. In post-operative, the vision improved to 618 and control of exotropia improved. Stereopsis documented was 160 seconds of arc. This is the pre-operative and post-operative table, which we have already discussed one by one with the patient. The post-operative results at 12 weeks post-op showed binocular single vision and improvement of stereopsis on Rendot in all 4 patients. The refractive correction closer to the nodal point improves visual acuity. A clearer and lesser NIC iconic image would stimulate and enhance the binocularity. For high refractive errors, glasses create significant peripheral distortion. Surgical correction of the refractive error provides the patient with a larger distortion-free peripheral field and a stronger stimulus for fusion. So greater accommodative effort would help in controlling the exotropia. Greater pseudo-accommodative effort with multifocal IOS in the first case, and enhanced effort by the phakic IOL in the third and fourth case will play a role. So from this, we conclude that these cases demonstrate orthoptic relevance of surgical refractive correction in unilateral high refractive errors in young adults as an essential part of the initial management of strabismus. Thank you.
Can you show me case number 2 once again?
Yes.
So, there was suppression before, right?
Yes, ma'am.
And you say that after putting the lens, the suppression has gone and stereopsis has improved just by
Improved.
putting a piggyback IOL.
Piggyback IOL.
How is it possible? How is it possible? Can you explain?
Ma'am, till 7 years of age, patient may have enjoyed binocularity, and after that, when he got injury, so after that, with -8, he became 612. So the image size and acunia must have played a role so that he is not able to enjoy binocularity when we corrected at the nodal point through piggyback IOL, so stereopsis improved.
Now come to the third case. Here you are saying there was an exotropia of 30 prism diopters,
Yes,
right?
ma'am.
And there was an anisometropia also of -20.
Yes, ma'am.
How do you explain this?
Ma'am, we implant, ma'am,
You are
ICL
basically
was,
from which institute? Can I know
ma'am,
that?
KGMC,
Hmm?
King George Medical College.
Where?
The research was done at KGMC
Okay. Hmm.
under guidance of Professor Siddharth Agarwal, sir. ICL was implanted in both eyes, ma'am, and the stereopsis and correction also improved. This is the post-operative photograph of the patient.
Hmm.
So
Just
the
come to the
control
previous
improves
slide.
with when we correct at the nodal point.
Please go to
in
the
I-
previous slide.
Yes, ma'am.
Yeah. Now explain. You're coming to 160 seconds, right?
Yes, ma'am. 1 6 seconds
So
of arc.
how much XT was left?
How much?
XT was left.
Ma'am, control was much better. Only 10 PD of XT was on cover and uncovered.
So that is also, you have written ortho for distance in here. You
Yes,
have not
ma'am.
mentioned the XT, what is left. That is supposed to be mentioned in
Ma'am,
this.
10 PD, which is in general practice also we see.
10 PD में फोविया में कहाँ पे तुम्हारा आएगा नोडल पॉइंट से कहाँ इमेज बनेगी ये बताओ मुझे.
I didn't get that.
Where, like if you are getting it fovea, okay, then stereopsis will improve much better, okay. So now coming, where is your image? You are getting 160 seconds of arc
Yes, ma'am.
and it is 10 PD. Where the image will form?
Ma'am, fovea.
फोविया में कैसे बनेगी? 10 PD है तो कैसे बता भैया फोविया में कैसे बनेगी?
Ma'am, the patient was orthophoric for distance and near. Only
Post operative you are
angle
saying.
kappa was there when we saw post operative.
Now you are changing your statement.
Basically, what is the basic rule in relation to the suppression amblyopia? Right? You are describing the children, not children,
Adults, 20
more
years.
than
20, 21 years.
20, 21, 22, and saying that there was amblyopia, and you are also saying that up to the 12 years of age, children were enjoying with the binocular vision.
No, only the second case must have been injured, since he got injury at 8 years of
But how
age.
do you know that he was having the binocular vision? When the child has presented to you at the age of 20 years of the trauma or whatever it may be.
Yes, sir.
So how do you know the things of the 8 years back?
Yeah.
We can only assume that, sir, in that case.
What is the sensitive period? Do you know? I think you might be aware of the
Yes, sir.
sensitive
Yes,
period
yes.
in relation to the
Yes, yes.
amblyopia
Yes,
as well
sir.
as the suppression,
Yes, sir.
right? And suppression is also of the 4 types.
Yes, sir.
You have not described, once you are describing the research activities,
Yes,
you
sir.
should also say that this type of suppression is there.
Yes, sir.
And how,
That
is
I
it,
noticed,
how
yes.
does it respond to the refractive correction
Yes, yes.
with the child, right? Anyway,
Sir,
any other question?
one more question. Sir, case 3, he's telling 21 years of female with XT with so much of anisometropia. So, how can you eliminate suppression? It'll go into intractable diplopia, yaar. It's minus 20 and 30 PD.
Yes, ma'am.
So the patient will have diplopia if suppression goes off. Patient cannot have, how can you explain it? I'm not getting it, how it is done.
No, he must be concentrated only the orthoptic improvement. No?
Yes, sir. Only orthotic improvement.
You must say that the squint has been corrected or not corrected, binocular vision will be there or not there. So these are 2-3 points which has
He's
to be.
saying stereopsis, 160 seconds.
I'm explaining. He is not right. So probably these things must be discussed with your guides and all that. Siddharth and Vinita. Vinita probably
Yeah,
left, I think.
Vinita Singh ma'am has left.
Quite back.
Yes, sir, yes.
Right. So only Siddharth might be there.
Yes, sir.
Anyway,
Okay.
good presentation.
Thank you.
Thank you, sir. Thank you.
Thank you.